Hello guys, welcome back, and this is our last pharmacology review. And our topic today is antivirals. Just some general principles for antivirals. I think it's helpful to kind of group it into one slide. The goal for antivirals is to prevent viral replications. And before we go into the specifics, I just wanted to review really quickly um, just basic terminology: nucleoside versus nucleotide. So nucleoside is the base and the sugar, and nucleotide is base, sugar, and the phosphate. So if you start looking at antivirals, you want to ask the question of how do they prevent viral replications? So the first group of antivirals terminate replicating chains. So they go into the chain and they insert themselves there, and they cause inhibition of DNA polymerase and thus causing inhibition of viral replication. So the classes of medications that do that are the nucleoside and the nucleotide analogs. Um, the nucleoside analogs, example of these is the acyclovir, ganciclovir, and trifluridine. And the nucleotide analog, there's only one of them, is cidofovir. So these medications are inhibitors of viral DNA polymerase by terminating uh, the chains. So these are base analogs. Um, there's another group of medications that goes and directly inhibit the DNA or RNA polymerase, and that's foscarnet. There is another way of inhibiting viral replication is to go from the beginning and actually inhibit new base synthesis, and ribavirin does that exact thing. It inhibits new base synthesis. Fourth way of inhibiting viral replication is um, inhibiting the virion release from the cells. And oseltamivir, which is Tamiflu, it's used for the influenza, does that. The viruses are already made, but they can't get out of the cells. And oseltamivir does that. And lastly, one way of inhibiting viral replication is to inhibit viral uncoating, meaning the virus has a coat, and in order for it to penetrate the cell, it has to uncoat or take out its coat. Um, and if the virus can't do that, then it can't go into the cell and replicate. So amantadine does that, inhibits viral encoding. So this is the basics or the general principles of the antivirals. Um, Not sure why oh, here we go. So let's go into the specifics of these antivirals. So what we're going to talk about right now is the base analogs, or the nucleoside and the nucleoside analogs. And these medications specifically target herpes, varicella, and CMV. The first medication that we're going to talk about is acyclovir and valacyclovir. Acyclovir is an IV form. Val acyclovir is just the oral form of acyclovir, and it's better absorbed. How it works is that it's a guanosine analog, it's a nucleoside analog. It goes and it's phosphorylated by an enzyme called thymidine kinase, and this thymidine kinase is uh, natural to the virus, and it adds a phosphate group to the acyclovir, and it becomes pretty much a base and inhibits viral DNA polymerase by chain termination. The most important thing in this is that it's phosphorylated by viral thymidine kinase. The test question will ask you there's a drug that's used for a virus, and this drug is phosphorylated by an enzyme. What is this enzyme? And the enzyme would be thymidine kinase. Or the question will ask you there is a drug that's phosphorylated by thymidine kinase. What is this drug? And the drug would be acyclovir. It's used for HSV, so herpes encephalitis, and herpes ulcers. It can also be used for varicella. Side effects for acyclovir specifically is that it concentrates in the kidneys. So if the patient is not well hydrated, it can cause acute renal failure. And that's also a high yield point. It causes crystals, um, and that's how it causes acute renal failure. And I've actually seen 2 or 3 questions on UWorld or some of the other question banks talking specifically about this. So this is a high yield point for acyclovir. Ganciclovir and valganciclovir are also nucleoside analogs. They're guanosine analogs. They are phosphorylated by CMV viral kinase, and um, they inhibit the DNA polymerase. It's these medications are specifically used for CMV. So acyclovir and valcyclovir, they're used for HSV and VSV. Ganciclovir and valganciclovir are specifically used for CMV. So CMV retinitis or systemic CMV, and also used for prophylaxis in transplant patients because they're immunocompromised and they are at a greater risk for CMV. Ganciclovir is more toxic than acyclovir, and specifically it causes bone marrow suppression, specifically neutropenia. Renal failure, not as much, but the one thing that I want you to remember is that it causes bone marrow suppression. Next group of drugs, or next class of drug is the foscarnet. And you remember when we talked about foscarnet is that it directly inhibits DNA and RNA polymerase. So it goes and binds to this pyrophosphate site, and it's specific to DNA and RNA polymerase and thus inhibiting replication. Foscarnet is reserved for resistant HSV and CMV, and the reason it's reserved for resistant HSV and CMV is because it has a bunch of side effects that are generally not well tolerated. It causes nephrotoxicity, but the biggest thing that shows up on exams is electrolyte imbalance. So hypokalemia, hypomagnesemia, and calcium. And you world question or any question bank will ask you. This is a patient that has resistant CMV and was started on antiviral medication, and now their potassium is, I don't know, 2.8 or 2.5. What is the cause? And the cause will be foscarnet. So it's very important to know this side effect. Trifluridine is not a high yield drug, but you can know it. It's a nucleoside analog. It's a topical medication. It's eye drops, and it's used for HSV keratoconjunctivitis. Cidofovir is not on your exam, but it's important to know it for the boards. This one is a nucleotide analog. So all of the medications that we talked about, these ones are nucleoside analogs. So they need to be phosphorylated. This medication, cidofovir, does not need to be phosphorylated. So it's a nucleotide analog. It doesn't require activation by viral kinase. It's specifically used for CMV retinitis. The high yield point for cidofovir that it's a nucleotide analog. So we talked about herpes, varicella, um, and CMV. Now let's talk about viral respiratory infections. And the main one is the influenza and RSV. Specifically targeting influenza is oseltamivir, which is Tamiflu. I'm sure some of you have taken Tamiflu before. And Tamiflu is kind of a cool drug because it's important. Its mechanism of action is actually pretty unique. So we know that the influenza virus attaches itself to the host cell using hemagglutinin via sialic acid. So it goes and kind of attach itself to this protein hemagglutinin via a linkage called sialic acid. How it gets out of the cell, of course, after it replicates, the influenza virus wants to get out of the cell. And how it does that is that there is this enzyme called neuraminidase, and it cleaves the sialic acid and allows the virus to be released. When you give oseltamivir, which is a neuraminidase inhibitor, you cannot cleave the sialic acid. So if you can't cleave the sialic acid, the virus is going to be stuck to the hemagglutinin, so you're not going to be able to release the virus. And thus, you inhibit viral progeny release. Progeny means daughters. So it's very important to know the mechanism of action of oseltamivir. It's specifically used for influenza A and B. The time frame for usage is within 48 hours of symptoms. Otherwise, it doesn't really work. And the benefit of oseltamivir is that it shortens the duration of the illness by 2 days, I believe. And it can also be used as prophylaxis. Side effects for oseltamivir is really nothing. Zanamivir is an inhaled form, and it causes bronchospasm. Of course, anytime you introduce a medication to the lungs, you have the risk of the bronchospasmic. Next medication that is used for viral respiratory infections is ribavirin. Ribavirin, if you remember, it inhibits new base synthesis. So it specifically inhibits the guanine synthesis. And if you remember, ribavirin inhibits this enzyme called IMP dehydrogenase. If you go into your purine synthesis pathway from biochemistry, you can remember that IMP dehydrogenase is one of the enzymes that lead to guanine synthesis. So if you inhibit this enzyme, you inhibit guanine nucleotide synthesis, and then you're not going to have enough guanine, and then you're not going to make viruses. Ribavirin, it's also ribavirin is used for RSV in children, and it's aerosoled, so you give it via the lungs. Oral ribavirin is used for hepatitis B and C, and that's something we're going to talk about in a little bit later. Important thing for ribavirin is that it causes anemia, specifically hemolytic anemia, but the important side effect for ribavirin is that it's teratogenic, and that's something that's important to know. Amantadine is not on your exam, but it's important to know for your boards. Amantadine is a medication that used to be used for the influenza. It inhibits the M2 protein, which is a protein that's used for viral uncoating. So if the virus can't uncoat, then it can't penetrate the cell. It's not used for flu anymore because it has a lot of the resistance, but it's used for Parkinson's disease because if you remember, we talked about amantadine, that it increases dopamine in the synapses. So amantadine is used for Parkinson's. Um, Now I wanted to kind of take a moment and speak about viral hepatitis. Viral hepatitis is a complex topic, and it doesn't do it justice to have one or two slides about it, but I'm going to try to kind of give it to you in a very short, concise format. The medications for hepatitis are a few medications. There is interferon alpha, ribavirin, and these new targeted medications, Harvoni, which is the brand name, consists of lidibasivir and sofosbuvir, or lidibasivir and cimipravir. So starting with interferon, interferon is I would say a product of your macrophages, but we've synthesized interferons. And how it works in the setting of hepatitis is that it interferes with viral protein synthesis. It's used for hepatitis B and C plus ribavirin. However, this use has really fallen out of favor because interferon has a lot of side effects, and then we have more beneficial treatment for hepatitis B and C. But it's important to know interferon because if patients are or if you see patients on it, it has a lot of side effects. The biggest side effect is that it causes depression, and it causes myopathy, so a lot of muscle pain, and it causes neutropenia. So these side effects are important to know for interferon. As a side note, I wanted to talk about interferon. There is a bunch of interferons. There's interferon alpha, there's interferon beta, and there's interferon gamma. And I wanted to kind of bring it to you in one place. Interferon alpha is used to treat viral and cancer. And there's a section in first aid that specifically talks about interferon alpha. Interferon beta It's used to treat multiple sclerosis, and interferon gamma is used to treat chronic granulomatous disease. So these are the three different interferons. Ribavirin, as we talked about earlier, it's used for hepatitis B and C along with interferon. The last medications are really, these are the newest on the market. Um, there is three of them that I want you to know: lidipasvir, sofosbuvir, and cimipravir. And in general, these are not as high yield, but it's also good to just be generally aware of them. Lidipasvir, it inhibits a protein called NS5A, and this protein is involved in viral replication. So fosbuvir is a chain terminator, so it's incorporated in the RNA and it acts as a chain terminator. It also inhibits RNA-dependent DNA polymerase. And cimipravir, it's a hepatitis C protease inhibitor. I would say if you're going to remember anything, I would remember lidipasvir, which inhibits NS5A. These medications are really the backbone of hepatitis C treatment. Harvoni, which is lidipasvir and sofosbuvir, is curative in hepatitis C. It costs so much money. I think the last time I checked, that it cost nearly $100,000 for 12 weeks, which nearly is $1,000 per pill. That's just a side note. That's not something that you need to know. Summary for antivirals that I wanted to kind of bring it in one slide. HSV use acyclovir, foscarnet, and trifluridine. Varicella use acyclovir. CMV, ganciclovir, foscarnet or cidofovir. Influenza use oseltamivir, which is Tamiflu, and amantadine, but not really anymore because of resistance. RSV use ribavirin. Hepatitis B virus, you use two medications that we're going to talk about in the HIV section, tenofovir and lamivudine, or the second line agent, which is not really preferred, is interferon and ribavirin. Hepatitis C, curative is lidipasvir and sofosbuvir, plus or minus ribavirin. So this is just a summary of antivirals. Next, we're going to talk about HIV/AIDS. Hey guys, welcome back to our last topic in pharmacology review for the year, which is HIV and AIDS. So, as always, we like to start with the general principles of treatment for HIV. And really, the goal for HIV, as well as any viral infection, is to prevent viral replication. HIV is a complicated virus, and the treatments are also quite complicated. So it's very, very important for you to understand um, the principles of the treatment. So that's why I kind of put it into one slide. The first step that we can really do in preventing HIV replication is to prevent the fusion of HIV virus into the host cells. And we can do that by two different ways. We can prevent docking of the virus into the host cell, and that is accomplished by using a drug called maraviroc. Or we can prevent fusion and entry of the virus into the cell, and that's a drug called infuviritide. Infu from fusion. Um, so that is the first step that we can do. The second step that we can do is that we can inhibit reverse transcriptase. As you know, HIV uses reverse transcriptase enzyme to go from an RNA to a DNA strand. So we can use that for our benefit. So inhibiting reverse transcriptase is using three different classes of medication. First, the nucleosides. Um, those are the nucleoside reverse transcriptase inhibitors, mainly imitracydopine, abacavir, lamivudine, and zidovudine, or the nucleotides. There's only one nucleotide reverse transcriptase inhibitor that is available, which is tenofovir. And finally, versus via non-nucleosides. So these are this is a medication that goes into the reverse transcriptase at a different site than the base. And these are called the non-nucleosides reverse transcriptase inhibitors. An example of that is efavirenz. Um, so that's the next thing that we can do, is that we can inhibit the reverse transcriptase. The third thing that we can do is that we can inhibit HIV integration into the host cell genome, and that's using integrase inhibitors. And the suffix for that is gravir. An example of it is raltegravir. Raltegravir is an integrase inhibitor, and it inhibits the HIV integration into the host cell genome. And finally, we can inhibit the new virus maturation um, with drugs called protease inhibitors. So what happens is that the HIV replicates. It makes a long, big strand of RNA, and it needs to be chopped up into small active particles of the virus. And the how that happens is using protease enzymes. So inhibiting the protease actually inhibits the maturations of these new viruses. And the suffix of the protease inhibitors is nevir. So first, let's start with our nucleoside reverse transcriptase inhibitors. So there are four medications that it's good to be aware of: imitracydopine, abacavir, lamivudine, and zidovudine. And since these are nucleoside reverse transcriptase inhibitor, do they need to be phosphorylated or not phosphorylated? Yes, they need to be phosphorylated. So they go in and they get phosphorylated, and uh, the drug binds to reverse transcriptase, and reverse transcriptase thinks it's an actual base, and the chain gets terminated. The DNA chain gets terminated. These medications are actually the backbone of antiretrovirals. Um, Lamivudine is specifically used for patients that are co-infected with HIV and hepatitis B. Zidovudine is a very, very, very high yield drugs because it show up on exams all the time. The reason for that is um, it can be used in pregnancy and infants. So zidovudine, it can be used for pregnant HIV mothers, or it can be used for prophylaxis for infants at risk of HIV transmission. It's very, very important to know zidovudine. Side effects for NRTIs are also important. Abacavir has a very, very specific side effect, and for that reason, test examiners love to test abacavir. So abacavir can cause hypersensitivity in patients that have this specific mutation, HLA B5701. And patients that are of Asian descent have a high risk of having this specific mutation, and we test a patient for HLA B57.1 before starting abacavir. It's very, very important clinically, and it's very important from a test examination standpoint. Zidovudine, which is the medication that's used for pregnancy, can cause myelosuppression. So anemia um, and um neutropenia as well. Zidovudine can also cause lipodystrophy. And lipodystrophy, just a fancy word meaning that the fat is distributed from different places, from the face to, for example, the trunk. Didanosine is an NRTI, and didanosine is important because it has the side effect of pancreatitis. While it's not very important clinically, but it shows up on test exams all the time. So we talked about the nucleoside reverse transcriptase inhibitors. So these are the drugs that need to be phosphorylated. Our next drug is a nucleotide reverse transcriptase inhibitor, and the drug is tenofovir. And tenofovir does not need to be phosphorylated. It has the same mechanism of action. It goes and tricks reverse transcriptase enzyme into binding to it, and it inhibits uh, causes DNA chain termination. Tenofovir is not really used as an antiretroviral, but it's mainly used to boost the levels of other drugs, the protease inhibitors. What do I mean by that? So we know that antiretrovirals have a lot of drug interactions, and they go through the CYP450 enzymes. Tenofovir has been found to inhibit some of the CYP450 enzymes that metabolize protease inhibitors. So if you think about it this way, you have these CYP450 enzymes, and they go after the protease inhibitors and they degrade them. You give them tenofovir and you inhibit the CYP450. Now you're going to have more protease inhibitors that go after the HIV virus. So tenofovir is mainly used to boost levels. It's not really used as an antiretroviral. It's also active against hepatitis B, so it's a side note to be aware of. Next class of medications are the non-nucleoside reverse transcriptase inhibitors. So the difference between those and the nucleotide or the nucleoside reverse transcriptase inhibitors is that the non-nucleosides go into a site different than the NRTI. So they don't dock into the main reverse transcriptase site in a chain termination, but they go into a different site. These don't really need phosphorylation, um, and they're used in HIV. I forgot to mention the examples: efavirenz, rilpivirine, and itravirine. Efavirenz is the high yield one to know. Side effects: they cause vivid dreams and they contraindicated in pregnancy, and they have a lot of drug interactions. I don't want you to know the specifics, but know that efavirenz is the high yield one. It's an NNRTI and drug interactions. Our next class of antiretrovirals are the protease inhibitors. So the protease inhibitors, they end in navir. So atazanavir, lopinavir, and ritonavir. How these work is that they inhibit the protease enzyme, HIV-1 protease enzyme, and this enzyme cleaves, as I mentioned earlier, cleaves the HIV polypeptide products into functional parts. So when HIV is made, it's made into this long chain, and it needs to be chopped up in order to be fully mature. So the test examiner love this statement that protease inhibitors prevent maturation of new viruses. Um, Side effects for protease inhibitor, the famous one is lipodystrophy. So if you think of protease inhibitor, they have a lot of metabolic side effects. So they cause lipodystrophy, and they also cause hyperglycemia and dyslipidemia. They also have a lot of drug interactions. This is a side note: ritonavir is also used to boost some of the levels of protease inhibitors. Um, Next is our integrase inhibitors and the fusion inhibitors. So an example of the integrase inhibitor is raltegravir. So these are the medications that end in gravir. And like what we talked about earlier, these medications inhibit the integration of HIV into the cell genome. So they go after this specific enzyme called HIV integrase, and that enzyme helps the HIV genome to integrate into the host cell genome. They are main side effect is increase in creatine kinase, but the high yield point is the gravirs, raltegravir, or integrase inhibitors. Next are our fusion inhibitor medications. And the basics for fusion is we know that HIV needs to fuse, to attach and fuse into the cell in order for it to start its life cycle. So there's two different receptors that I would like to review. So on the HIV itself, there's two different proteins, the GP120 and the GP41. The GP120 on the HIV virus attaches to receptors. These are the CCR5 receptor on the macrophage or the CXCR4 on the T cells. So you have the GP120 on HIV goes two different ways, CCR5 on macrophages and CXCR4 on T cells. So that's the first protein. The second protein is GP41, and that's required for fusion in entry. So there's drugs that kind of target these proteins. So enfuveritide is a medication that targets fusion because it binds to GP41, so it blocks its fusion and entry. It's a medication that's used subcutaneously. Maraviroc is an attachment inhibitor. So it binds to CCR5, which is the receptor on macrophages. So it inhibits attachment and docking. As much as I don't like memorizing, but it's really important to know these specific receptors that these fusion inhibitors go after. Lastly, I just wanted to kind of put a little summary together for HIV as far as who gets treated. So patients that have an HIV diagnosis regardless of a CD4 count are generally recommended to start treatment, especially if CD4 is less than 500. AIDS defined an illness is an indication for HIV treatment, and of course, pregnant mothers and infants that are risk, they are to be treated specifically with zidovudine. The regimens, they're complicated, but in general, you don't use one drug because of resistance. You use a combination, and it's usually three medications. The backbone is two NRTIs, so the nucleoside reverse transcriptase inhibitors, so efavirenz, emtricitabine, or abacavir, plus one of the following, either a PI, protease inhibitor, integrase inhibitor, fusion inhibitor, or an NRTI. And also, not in your lecture, but kind of related to HIV, I wanted to kind of give you a summary of patients that should get prophylaxis if they have HIV. So the biggest three bugs that we prophylax against for HIV are PCP, Toxo, and MAC. PCP, you prophylax if the CD4 is less than 200, and you use Bactrim, which is sulfamethoxazole and trimethoprim. If patients have sulfa allergy, you use dapsone or pentamidine. Toxo, you prophylax if the patients have CD4 less than 100, and you also give Bactrim and dapsone if patients have sulfa allergy. MAC, you prophylax if the CD4 is less than 50, and the prophylaxis you give azithromycin or clarithromycin. So that really ends our last section of the last review session of the year. I can say that it's really been a pleasure doing these review sessions for you guys, and I really hope that you benefited from it. The one request that me and Mike ask of you is, as you know, we're doing this research study that kind of compares med students' um, beliefs regarding pharmacists, and we wanted to compare it before and after these review sessions. So we'll send out the survey, and if you can find just 5 minutes of your busy schedule, if you can fill out that survey, that would uh, greatly help us, and it would be greatly appreciated. In addition, we also would like just personal feedback on the review sessions. What worked for you? What didn't work for you? If you used it, what could it be improved? We hope to continue these review sessions, but we want to know how is it generally received. So that's something that would be greatly appreciated if you give us feedback, and we'll also send a survey regarding that. So again, we've really enjoyed teaching you guys these pharmacology review sessions, and you have a now you have a basic understanding of of drugs, and drugs are an important part of of what you're going to be doing as a physician. So I really came across recently came across this quote by Hippocrates, and um, it was saying that the role of the physician is to cure sometimes, treat often, and comfort always. And you'll have your medical knowledge and the drugs that you've just learned to cure sometimes, and maybe to treat, but very minimal to comfort. And it will be on you to comfort. And I know right now, you don't really have the means to comfort. You're studying in your room, and you're really stuck in this step one mode, but really know that you will have a chance to comfort, and you will have a chance to really make a difference in people's lives. With that, I wish you guys nothing but the best. If you have any questions, or if you'd just like a word of encouragement, please reach out to me or Mike, and would be glad to talk to you. Thank you.